hoping to get some recording done in the past couple of days. So this morning I basically shut my door and did what I could, and did not get as far as I wanted to, and in the process actually found out I have even further to go. So this is what I've gotten of the digestive system so far. I was under the impression that meant I only had one last thing to do, which was on nutrition and metabolism. But as I was putting that one together, I realized I never had one. I didn't make one about absorption and secretion. So I actually have two more to do, which I might have been able to convince to get that last one done during my lunch break or something like that. But I'm definitely not going to get two done today. So I'll try to work on that. So that's the state of recording right now. For you guys, I'm probably going to be able to get things done kind of on time. But my afternoon class today, they did the digestive system last week, so I'm already behind their schedule. But so I'm trying to get it done. Yeah.
Is there any way you can adjust the due dates of the assignments? Because you haven't finished learning the digestive system, but it was due 3 days ago.
Yes, there is. Actually, while I'm thinking about that, let me do that right now. In this particular course, the way that it's set up, this is annoying because I have to, I set things up, early on, and then things just come up. Okay, so yeah, they were done too. Let me think here. I'll just go ahead and push them. I want to push them back too far. Let me do this. Okay, so I'll push them back to when the urinary system stuff is due, because that's probably more realistic to when we'll complete the digestive system stuff. And then yeah, I think that's going to have to kind of do, depending on where we are in the material, I might push the urinary system back a little bit further, but hopefully that'll work out. So at least that handles the digestive system stuff. So that's not due till, what did I just put that on, next Wednesday? All right, yeah. Okay. So yeah, thanks for getting me to do that right now. So I probably, if I said, oh yeah, I'll push it back, I'd probably have forgotten about it anyway. So anyway, so I'll try to get the other recordings up so you have more material to work from on those. But the style of this class is meant to give it to you in sort of lecture format here in class as much as possible. So let's just get into the digestive system. The structures of the digestive system here, the contents. So what they are, separating them into the digestive tract and the accessory organs, and then the structure of digestive tract organ wall. I covered all that in lab. And I talked about the plexuses. Might not have, I know I mentioned the peritoneum, that's the name for the serosa. I might not have shown you this picture. This is a section through the upper abdomen, and they're just showing you the thick line is the peritoneum, which is covering the outside of the organs and lining the inside of the cavity there. So that's just a representation of where the peritoneum lies there. There is a separate section here at the beginning about processes and regulation. What I did last time, the list of the digestive processes, which I spent a lot of time talking about enzymes there, is kind of covered here in the book. There's 4. Wasn't there a list of 5 that I gave you? Yeah, it was digestion, propulsion, secretion. Yeah, okay. So there are 2 boxes here for digestion, chemical digestion, mechanical digestion, and then propulsion and absorption. They don't have a box specifically about secretion or elimination, although elimination is really just defecation is the word there at the end. But this kind of highlights what those functions are. We'll cover those functions more specifically as we go through the system. So we're going to start with looking at the mouth, pharynx, and esophagus, which is the upper GI system, upper GI tract. And then the next section specifically on the stomach, and then the section after that specifically on the intestines, and then after that the accessory organs. So we'll just move through the structures of the digestive tract, and then at the end pick up the accessory organs. And in that, talk about the processes and functions that are specific to each. So 2 things that we really want to consider in terms of the upper GI are chewing and swallowing. Chewing is the mechanical digestion that breaks the food down and mixes it in with saliva to begin to make it into a more homogeneous, pasty consistency. And then swallowing is the physical movement of the food from the oral cavity, eventually down to the stomach. So here's a beautiful picture of the open mouth, highlighting where the teeth are and pointing out other structures. As far as chewing is concerned, and there's not exactly a picture that shows chewing, but as far as chewing is concerned, the tongue helps to move food around inside of our mouth, and we can position the food between our teeth. And then the muscles of the lips and the cheek can help to trap the food between our teeth, so we can use our tongue to push the food towards our cheek, and then as our cheek muscles contract, we sort of push back against that, and that traps the food between our teeth, and we can chew on them. We talked about the tongue in terms of taste, and so I talked a little bit about its structure back then. This picture kind of revisits that and also points out where tonsils are located around it. And we talked about the tonsils in terms of the lymphatic system. As we chew, that helps to mix the food in with the saliva. So this picture represents the 3 different salivary glands. The parotids are located around the jaw's joint, the temporomandibular joint. Here we don't see that joint, but the muscle that's adjacent to the parotid gland there is one of the muscles of mastication, which is right across that joint. And then the sublingual glands are underneath the tongue, and the submandibular glands are at the base of the mandible. We're looking at one of each of these. They're paired. There's a right and left of each one. The parotid glands ducts empty out into the upper regions of the oral cavity, and the sublingual and submandibulars empty out underneath the tongue. If you are planning on going into dental hygiene, this is about as specific as anything gets to address the teeth. I'm not going to go over them. You can look at it with in your own depth of interest. We don't have 2 sets of teeth in our mouth, like an alien or something like that. This is showing you the larger upper and lower ones are the teeth that we find in the adult, and the smaller ones in the middle are the teeth in a child, which are replaced as they fall out, and the tooth fairy comes, and you know the whole story, right? And this is just the basic structure of a tooth. This is a molar, one of the back teeth. Not exactly what we'd see for, say, the incisors along the front. But the pharynx was introduced with the respiratory system. This picture kind of shows the upper respiratory tract and the upper digestive tract together, because the oropharynx and laryngopharynx are part of both of those tracts. The nasopharynx is not. The nasopharynx is strictly part of the respiratory tract. And the epithelia that we see lining these tracts represents that. We have the pseudostratified epithelium of the respiratory tract in the nasal cavity and the nasopharynx. And then when we get to the lower respiratory tract, for the digestive tract, upper digestive tract, we have a stratified squamous epithelium in the oral cavity and in the oro and laryngopharynx to help protect against potentially hot or acidic or whatever foods that we might ingest, which continues on down the esophagus. So this is just sort of highlighting the crossing over those two tracts there. The esophagus is not a terribly exciting organ. It's really just a tube that conveys food from the oral cavity down to the abdominal cavity. There are sphincters at either end that regulate the movement of food into and out of the esophagus. The upper esophageal sphincter and the lower esophageal sphincter. Some sources will just ignore the upper esophageal sphincter. It's really not that big of a deal, perhaps. And instead of referring to the lower esophageal sphincter as the lower esophageal sphincter, which suggests that there must be an upper one, those sources will often call the lower esophageal sphincter the gastroesophageal sphincter. And the gastroesophageal sphincter is very important because it is there to keep stomach contents from getting back into the esophagus. It's not a perfect system. People have heartburn under certain circumstances. Probably everybody at some time in their life has experienced heartburn. Some people suffer from it on a regular basis and they take medications to regulate it. Sometimes that can come because a little bit of the stomach can poke through the diaphragm into the thoracic cavity. That's what we call a hiatal hernia. The diaphragm goes across the boundary between the thoracic and abdominal cavities. So there's an opening in the diaphragm right around the end of the esophagus called the hiatus. A hernia is any time that soft tissue pokes through a muscular wall. We usually think of hernias as the inguinal hernia, which is where a little bit of small intestine pokes through the pelvic wall in the inguinal region of the groin. But a hiatal hernia is where a little bit of the stomach will poke up through the hiatus on the other side, which really causes problems as far as heartburn is concerned or reflux is concerned, because that little bit of stomach will produce stomach acid, but the lower esophageal sphincter and the hiatus both are not able to pinch off between the esophagus and the stomach. So the little bit of acid that's produced in that hiatal hernia will just automatically spill out into the esophagus and cause the sensation of heartburn. So that can be a little bit more chronic version of that. Now, what's important about the process of swallowing is called deglutition. It has two major phases. There's the voluntary phase, which is really describing what you do in your oral cavity with your tongue and cheek and lip muscles to move food around. And as you're chewing food, you're able to move food towards the back of your mouth, and once it gets to the back of your mouth, that'll stimulate the involuntary phase of swallowing, the reflexes that get the food to go down from there. Now, the book doesn't say voluntary phase and involuntary phase. They just take the involuntary phase and split it up into two different phases called the pharyngeal and esophageal phase, which is fine. They're making a point that these two regions don't quite work exactly the same, mostly because the pharynx has muscles that are arranged in a particular way for the pharynx because of the respiratory functions that the pharynx plays a part in, namely speech. So it's not as straightforward as the circular and longitudinal fibers that we talked about before elsewhere in the digestive tract. But then when we get the esophagus definitely has those circular and longitudinal fibers in them in its muscularis. So what's going on in the pharynx and the esophagus is a little bit different based on the anatomy of the two structures, but they're both involuntary, reflexive. The presence of food at the back of your mouth will initiate contractions of pharyngeal muscles to push the food down, as well as in the pharyngeal phase, the soft palate and uvula block off the nasopharynx so that food doesn't go up into your nasal cavity, and the epiglottis blocks off the lower respiratory tract so that food goes down the digestive tract. Once it's in the esophagus, those things aren't important because the food's moving onto the stomach from there. Now, in the esophagus, swallowing is performed through a process called peristalsis, which unfortunately, as I open this figure in a separate tab, you don't see the label for the figure that's in the book, but I highlighted in the figure name up there, the word peristalsis, if you can see that. Peristalsis is a common feature of the digestive tract, propulsion of the digestive tract. We actually see it all along the digestive tract in some degree. But in the esophagus, that's basically all that happens. That's what the esophagus is for. Circular fibers pinch off behind the bolus or packet or whatever you want to call it of food. And longitudinal fibers constrict, pulling the wall back along the bolus so that the bolus effectively moves down. Okay. And then continuing contractions of the circular fibers behind it and the longitudinal fiber contractions will end up pushing the bolus of food down the esophagus until it eventually gets to the stomach. Now, this picture isn't necessarily of the esophagus. It could be any of the tube structures of the digestive tract, but what we're seeing here is pretty much just what happens in the esophagus. There is a process called reverse peristalsis where the opposite happens, and that's part of moving food from your stomach up your esophagus and out your oral cavity. So that's part of regurgitation. Not a common occurrence, but it is a slightly different set of muscle contractions to move things in the opposite direction. Now, I'm mentioning this now as I'm talking about swallowing and referring to the esophagus, but actually peristalsis happens in a lot of different places. It's just usually layered on top of other processes that are happening. So I'm going to occasionally mention peristalsis or peristaltic waves that are moving things along while other things are happening in the system. So that's really all to say about the upper GI. It's a pretty simple area to touch on. So that leads us on to the stomach. Now, what I just talked about before, I was referring to as the upper GI tract, which means we're now in the lower GI tract. The stomach has its own section in the book and in the material that I present online, mostly because there's a lot to say about the stomach. But also, the stomach is a little hard to classify or a little complicated to classify in terms of upper and lower digestive tract. the classical way of defining upper and lower digestive tract is based on embryological development. I do not really address development in this class much of anywhere. I do in the nervous system, just because I'm very familiar with that, but I don't usually address it elsewhere. We're just talking about the adult system. And so embryological development of the digestive system isn't that relevant. But in the embryo, the components of the upper digestive tract, as I've defined it so far, and the stomach, and even a little bit of the small intestines, develop from one part of the embryo, and then the rest of the small intestines and the large intestines develop out of a different part of the embryo. So from a classical point of view, based on the embryology, the dividing line between upper and lower GI tract is usually somewhere in the small intestine. I want to point this out because if you look online, most sources will refer to that way of defining upper and lower. But in lab, when I was talking about this stuff, I defined upper and lower GI tract more anatomically. What is the big structure that we find between the upper GI tract and lower GI tract as I've been defining in the class? Big wall between the two. Diaphragm, right. So simply put, the lower GI tract is kind of everything in the abdominal pelvic cavity, and the upper GI tract is everything else. Also at that barrier, we see a couple of other anatomical differences. What is the epithelium lining the digestive tract superior to the diaphragm? Not simple. What's the opposite of simple? Stratified squamous. Yeah. Very protective. I mentioned that a little bit ago because we might be ingesting hot food or acidic food or something like that. And then what do we have inferior to the diaphragm? What's the other epithelium in the digestive tract besides stratified squamous?
Pseudostratified.
Nope.
Simple columnar.
Simple columnar, right. Which lines the stomach and the intestines. So the diaphragm and the epithelial changes, which occur at exactly the same place, help to establish the anatomical definition for the two. And then actually, I just realized this semester as I was doing these presentations, that there's another thing. What else is limited to just the the abdominal cavity? Anatomically speaking, what structure, as we mentioned, that's only in the abdominal cavity associated with the digestive tract? Okay, yeah, as far as how I asked that question, that applies, but let me put it this way. What part of the digestive tract is different, besides what we've already talked about, below versus above the diaphragm? I really think I said this explicitly in lab.
Tribone,
What's that?
bladder.
I talked about the layers.
Yeah, it has to do with the layers. So what layer? Sorry?
The serosa.
Right. So the serosa is only found in the abdominal cavity, around the stomach and the intestines, and the liver and pancreas and gallbladder. That the peritoneum is only in that cavity. Okay. The esophagus, pharynx, and oral cavity do not have a serosa. What they do have in place of it is a little different, depending on where we're looking, but they definitely are not like the lower GI tract in that sense. So I like to think anatomically of the stomach as being part of the lower GI tract or lower digestive tract. But another way we can look at it, which is relevant to this class, is from a clinical perspective. What, in a clinical sense, does upper GI usually refer to? If you go to the doctors and you get an upper GI, what are you getting?
Oral exam.
Well, not just an oral exam, that would be more like what a dentist does probably. But what else would you look at besides the oral cavity? The throat and,
Nose.
well, not for the digestive system, unless you tend to snort your food. So back to the original question, in a clinical sense, what does upper GI mean? When you get an upper GI, you're getting a camera stuck in through your mouth that goes down your esophagus and can look at your stomach and maybe even your intestines. Earlier I was talking about reflux and problems with that. If somebody has chronic heartburn, that's something that's going to be done. They're going to have a camera look down their upper GI tract and into their stomach to look at what the cause of reflux is. So somebody with a hiatal hernia, it'll be obvious that the cause is a little bit of the stomach sticking up above the diaphragm. Another cause of chronic heartburn is ulcers in the stomach caused by a bacterium, and an endoscopy, looking inside the stomach, can give evidence of that too. So from a clinical perspective, upper GI usually implies that you're looking at the oral cavity, the pharynx, the esophagus, and the stomach, and maybe even the very, very beginning of the small intestine. It's a lot easier to look at those structures with a camera stuck in through the oral cavity rather than stuck in from the other end. What do we call an endoscopy that's concerned with the lower GI tract? Yeah, colonoscopy. And it's called a colonoscopy because it only looks at the colon. You don't want that camera to move from the colon back into the small intestine. You don't want to push contents of the large intestines into the small intestine because that's going to potentially introduce bacteria to a part of your body that you don't want them to be. So you definitely don't want a camera to go in that end to look at your stomach. It's much easier to look at your stomach in an upper GI endoscopy. So from a clinical perspective, the stomach can be considered part of the upper GI as far as things that are relevant to this class. So the stomach has different regions, names for different regions. Where the esophagus attaches to it, that area is called the cardia, which obviously refers to the heart, because the heart is sitting right there next to it. Okay. Heartburn has nothing to do with the heart. It's reflux from the stomach into the esophagus. It's called heartburn because it feels like there's burning right here where your heart is. It happens to be it's where the esophagus meets the stomach, which is kind of right underneath the heart. You just associate the two together. There's also the fundus of the stomach, which is the part of the stomach that bulges up above where the esophagus attaches. The word fundus isn't unique to the stomach. It's a word that's used anatomically to describe anywhere that there's a part of an organ that bulges up above other parts of the organ. The front of your eye, where the cornea is, it sticks out a little bit from the spherical shape of your eye. That's called the fundus of your eye. Between where the fallopian tubes attach to the uterus, there's a little bulge above the fallopian tubes called the fundus of the uterus. So it's just a general term for sort of bulging parts of organs. So that's the fundus of the stomach. The majority of the stomach is referred to as the body, sort of all of this area here. And then it ends in a region called the pylorus. The pylorus actually has two portions to it, the pyloric antrum and the pyloric canal. Now, pylorus is referring to the valve or sphincter, it's referred sometimes by both terms, at the end of the stomach, separating it from the small intestine. As food's moving through the stomach, it's going to have to pass through that sphincter into the small intestine. And so the pyloric antrum and the pyloric canal are kind of leading up to that area. As you look at this picture, you might notice that the inside surface that's exposed of the stomach has lines drawn representing some little wrinkles. I'll talk about those wrinkles in a second, but in the body of the stomach and the pyloric antrum, those wrinkles are kind of at running in various directions. In the pyloric canal, the wrinkles run kind of parallel to and act as a funnel to direct the contents of the stomach towards the pylorus. So those are the regions, cardia, fundus, body, pylorus that has two parts to it. Those wrinkles that I just mentioned are called rugae, R-U-G-A-E. That's the plural. Singular is ruga, R-U-G-A. And this is actually something that's also not just unique to the stomach. We find rugae in other places. What rugae are folds in the mucosa of organs that have to expand. So your stomach, when it's empty, is pretty small, maybe about the size of a sandwich-size Ziploc bag. And when it fills up, it then can expand to about the size of a freezer Ziploc bag. Okay? It's roughly about a quart to a gallon transition in size. And the way that it can expand that much in size is that the mucosa is kind of all folded up inside when it's empty, and as it stretches out, those folds flatten out, allowing expansion of the stomach without having to stretch the mucosa inside, because a simple can't stretch to remain the shape they are. And so instead of making the cells stretch out, the mucosa is just sort of folded up inside, and those folds flatten out when it fills up. We see rugae in a number of other places. We're going to talk about it. They're found in the lining of the bladder and the lining of the vagina when we get to the reproductive system. Both are structures that have to change their shape to accommodate things moving through them. The bladder is a little bit special because it has rugae, but it also has an epithelium that can stretch. So we'll talk about that with the urinary system. The other thing that this picture points out about the stomach is that it has 3 layers of muscle tissue. When we're talking about the layers that make up the wall of the digestive tract organ, the muscularis had 2 layers, circular fibers and longitudinal fibers. The stomach, in fact, does have longitudinal fibers that run its length and circular fibers that go around it. But then it has a 3rd layer of fibers that run at an angle to those 2, called oblique fibers. That allows for the stomach to produce some very specific types of contractions. What's important about the stomach in terms of mechanical digestion and propulsion is that it has this churning action to it. Food gets to the stomach, and you're probably familiar with the consistency of food that you've chewed up and is in your mouth. It's kind of a pasty, damp consistency. When it gets to the stomach, it's going to get liquefied. It's going to mix in with a water solution in the stomach to help dissolve the molecules that make up our food a little bit more, which is going to make it easier for enzymes to get in. So it's a mechanical digestion process to liquefy the food. And that happens because the wall of the stomach, being very muscular, can churn the food up quite a bit. Now, in sort of peristaltic waves, which I said I'm going to mention a few times, these 3 layers of muscle tissue will push the contents of the stomach from the cardia fundus and down to the pylorus. At the pylorus, that sphincter will not open very wide. And so a little bit of the contents of the stomach will come out, but most of the contents of the stomach will be sloshed back the other direction. And so these waves of contraction just keep pushing the liquid contents of the stomach against the pylorus, most of which just churns back the other way. And that churning action helps to mix the food in with the liquid and liquefy the food. That liquefied food that we find in the stomach is called chyme. C-H-Y-M-E. Now, we don't only call it that when it's in the stomach, we call it that when it's liquefied food. So chyme moves out of the stomach into the small intestine and it continues on. Once we get past the small intestine and we're in the large intestine, we usually stop calling it chyme because it's no longer food at that point. It's indigestible material and we end up calling it feces. But the chyme's moving through the stomach into the small intestine. The stomach has the ability to expand and hold this huge volume of food, like that large pizza that you just ate last night. But the small intestine can't stretch out to hold that same amount of food all at once. It's long enough to hold all of that food as long as it's introduced very slowly. And so this churning action and the little bit of food that comes out with each wave will slowly introduce the food in the small intestine and it can move on, and then the next wave will push a little bit more out, and the next wave will push a little bit more out. So this churning action liquefies the food and it also slowly introduces the food into the small intestine. Now, the next section here down at the bottom, it says histology. It's looking at the structures that make up the wall of the stomach. So first off, the stomach has the 4 layers we talked about, mucosa, submucosa, muscularis, and serosa. The muscularis has 3 layers, like I said. The oblique layer is fairly thin compared to the other 2, but it's the deeper layer, it's adjacent to the submucosa. What's important about the stomach that we want to consider here in terms of histology is the structure of the mucosa and cells that make up the mucosal epithelium. The inner surface of the stomach was relatively flat looking at the cellular level or tissue level. The mucosa is wrapped around these rugae when it's empty, but you would see a fairly consistent, smooth inner surface with a bunch of holes or pits perforating it. And those gastric pits are the necks of glands that are deep inside the mucosa. Those gastric glands make the digestive juices that the stomach needs. Now, there's an inset here of one of the glands showing you some detail of the cells that make it up. And there are 3 types of cells that are mentioned here. There's actually a 4th type of cell to mention. They just don't have it represented in this picture because it's not exactly in the same place as the inset there. At the neck of the gland, so where it's labeled gastric pit, those sort of lightly shaded cells and the surface of the stomach, which are kind of colored the same as the neck cells, those cells all make a mucosa. Make a mucus. They are the mucosa. They make a mucus. What's made deep in the gland is what's added to that mucus, which is the digestive juice. And I'll talk about that in a second. But the mucus that's made here is very watery, and it's the liquid that the food's going to be liquefied into. What's important about it is it contains some chemicals or molecules that help to buffer the stomach so that the stomach acid that's produced by the glands won't burn through the mucosal lining. Okay, so that's not mentioned in this picture, but I do want to say that the cells at the neck of the gland, or the gastric pit part of this picture, and the surface secrete the very watery mucus, which contains buffers against the pH of the stomach. The other parts of the gland, what is highlighted in this inset, are three major types of cells that produce the juices. At the top of what we have here, these two cells that look kind of weird shaped are called parietal cells. They're responsible for making the stomach acid. Stomach acid is hydrochloric acid. So parietal cells secrete hydrogen ions and chloride ions, which in solution is hydrochloric acid. Then the majority of the cells that we see making up the rest of this inset here are called chief cells, which are responsible for making enzymes that are going to break down molecules in our food. The main enzyme that the chief cells make is referred to as pepsinogen. Pepsinogen is actually a proenzyme, meaning it's a precursor to an enzyme. What it's going to become is called pepsin. And pepsin, as the name of an enzyme, means something that breaks peptide bonds, essentially. That's what it does. It breaks down proteins, which is largely what's done in the stomach. The stomach's about digesting proteins. The thing is that we're made out of proteins. So the cells that make pepsin don't want to make active pepsin because that'll just digest the food, the cells that make them. So instead they make pepsinogen, which is a prohormone. Sorry, did I say that prohormone before? Proenzyme is the word I meant to use. There is such thing as a prohormone, which is a precursor to a hormone, but proenzyme is a precursor to an enzyme. And when pepsinogen hits a low pH solution, it gets activated. Pepsinogen can do one thing, which is to autocleave itself, which is to say, this will be kind of a weird, this will possibly be a little bit of a weird depiction, but let's say this thing here is an enzyme, and this loop right here is part of the active site. But as a proenzyme, that active site is blocked by a little bit of the hormone. Sorry, keep going. Enzyme. So pepsinogen, when it hits an acidic solution, will autocleave, meaning it'll cut part of itself off. And so this part of the protein will be removed. I'm not going to actually cut my little toy here. So pretend this part's going to be removed, which unmasks the active site. And now this is pepsin that can break down protein. You don't want pepsin to be active when it's being made in these cells because it'll digest the cell itself. So the proenzyme form helps protect the cell that makes that. And the enzyme is activated once it gets into the low pH. There are a couple of other enzymes that are made by chief cells, but pepsin/pepsinogen is the main one. And in this drawing, which you might not be able to see very well with the lights on this room, there are secretory vesicles drawn in the apical surface of these cells, suggesting that they're going to be secreting their enzymes into the lumen of the gland, which will eventually be continuous with the lumen of the stomach. The last type of cell, these two down here, are labeled as enteroendocrine cells. That word means literally gut endocrine cell, and entero is referring to your guts. So it's releasing a hormone into the gut. Now, in this picture, the secretory vesicles are on the basal side of the cell rather than the apical side because they secrete out into the lamina propria. Now, I more often, and actually the book and other places, refer to this type of cell as a G cell. The G in G cell is referring to the hormone that it's releasing called gastrin. Gastrin will increase the activity of gastric glands to secrete digestive juices, as well as it should have an effect on the muscularis to cause contraction a little bit. I'm not positive about that second one, but I think it can. What gastrin does is when the stomach is active and secreting its digestive juices, it's secreting gastrin, which will activate these cells to make more digestive juices. The stomach has food in it. It needs to be active to digest that food. And gastrin is kind of a positive feedback signal that increases the activity of the stomach. Now, back in the endocrine system presentation, I should have talked about autocrine, paracrine, and endocrine effects of hormones. You remember that? Okay. Autocrine is when a hormone activates the cell that secretes it. Paracrine is when a hormone activates neighboring cells without having to travel through the bloodstream. And endocrine refers to activation of targets at a distance after traveling through the bloodstream. The cell that I was talking about when I was describing those was in fact a G cell, because gastrin can do all three of those things. There are gastrin receptors on G cells, and so when gastrin is secreted, it activates the cell to secrete more gastrin. There are gastrin receptors on the chief cells and the parietal cells and the neck cells, so that when gastrin is secreted, it causes the gland to make more digestive juice. And then from one of these cells, so there's a couple on each of the plans here, gastrin can get into the bloodstream and go to other parts of the stomach and activate that tissue also. Or possibly get down to the muscularis area layer and activate that tissue. So gastrin itself can do all three things: autocrine, paracrine, and endocrine activation. And that was the example cell actually I was using when I was talking about that in the endocrine system. Now, I don't have a picture to show you right now, but there is one. Oh, there is a picture in the online presentation, but I keep forgetting. I can just pull one up here of a parietal cell. I'm just doing an image search for parietal cell. This is not the picture that I have in the presentation. There's a couple of shortcomings to this picture. And the picture I was eventually able to find depicts things a little bit better, a little bit more crudely. It's kind of a hand-drawn picture, but this addresses what I want to show you. The parietal cell is making stomach acid, hydrochloric acid. So it's pumping hydrogen ions out of the cell, and chloride ions are coming in the cell. It's not pumping HCl out of the cell. Okay. Everything's happening in solution, so you can just introduce those two ions to a solution, and that solution is hydrochloric acid. The hydrogen ion is pumped by a molecule that hydrolyzes ATP, and for the hydrogen it pumps out, it also has to pump in potassium. Potassium doesn't really do anything in this system, except that it's necessary for this pump to function correctly. If you didn't have potassium available for it, then it would stop after it pumped one cycle of hydrogen ions, because it has to pump hydrogen out and then potassium in, and then hydrogen out, potassium in, hydrogen out, potassium in. It is very closely related to the sodium-potassium pump, which pumps sodium out of cells and pumps potassium into the cell. It's just a modified version of that that pumps hydrogen instead of sodium. Two similar ions, but they're not the same ion. The hydrogen comes from carbonic acid, H2CO3. Being an acid in solution, H2CO3 will dissociate into hydrogen ions and, in this case, bicarbonate ions, which is the rest of the molecule. We were introduced to carbonic acid in the respiratory system, remember the red blood cell, during external and internal respiration. Depending on which way carbon dioxide was going, these reactions were taking place there. Carbonic acid, H2CO3, is carbon dioxide combined with water, H2O. So H2 and one of these O's and C and the other two O's make up the two components. What puts those together or breaks them down under certain conditions, but here puts them together, carbon dioxide and water, is the enzyme carbonic anhydrase, which is not represented in this picture, and actually I'm not positive it's represented in the picture I have in the online content, but it was introduced in respiratory system. So the enzyme makes carbonic acid, which then breaks down into hydrogen ions and bicarbonate ions. The hydrogen ions are pumped out into the lumen of the stomach. The bicarbonate ions leave the cell and go into the lamina propria and into the bloodstream, where they can help to buffer the pH of the blood. The bicarbonate that's produced in the red blood cell does the same thing. It goes into the plasma and helps buffer blood pH. But here, we're making bicarbonate for a different reason than what the red blood cells are doing in terms of respiratory function, but we have bicarbonate that's available to help buffer the blood. When bicarbonate leaves a cell, it necessarily means that chloride ions enter the cell. The bicarbonate transporter is tied to chloride. The chloride enters into the cell and then it just leaves the cell. Okay. And that gives us the chloride ion to have hydrochloric acid. So the carbonic acid reactions that were described originally for external and internal respiration for the respiratory system apply here as well, because we're making hydrogen ions that are going to make it possible to produce a low pH in the stomach. It also gives us bicarbonate ions available to the top of the stomach. Now, I said there were some shortcomings in this picture. One of them is they mention a sodium-potassium pump down here with no seeming reason to it. And the potassium they show here leaving the basal side of the cell, most depictions will show it leaving the apical side of the cell, so it just kind of cycles through here. All the potassium does is it allows the hydrogen pump to do its job. So once it's pumped in, it just leaves the cell. And most depictions show it leaving the apical surface, so it's available to be pumped back in later on. This pump is also sometimes referred to as a proton pump, because a hydrogen ion is just a proton. A hydrogen atom, when it's stable, is one proton and one electron. As a charged particle, hydrogen just loses that electron, and all that's left over is the proton. So H plus is a proton. And so the pump is sometimes referred to as a proton pump. There's a class of drugs called proton pump inhibitors, which will block the production of stomach acid. For people that have sustained or chronic heartburn, those can be helpful because it stops the production of stomach acid and you don't get the heartburn sensation. But kind of amazingly about these drugs, and I don't quite know why it works out this way, when your stomach needs to make stomach acid, when you have food to digest, the pump becomes so active that the drug can't inhibit it. So it really only inhibits acid production in between meals, which is when you really want to do it to keep those acid levels low. Because when you're digesting food, the acid is necessary for digestion and is handled just fine by the stomach. It's when between meals when it can be a problem. So proton pump inhibitors inhibit this pump right here. Does anybody take any proton pump inhibitors? Usually a few people in the room do. Does anybody know what the names of common proton pump inhibitors are? Prilosec, Nexium, omeprazole is the generic. Zantac, yeah, I think is one too, which is one of the early ones. It might work slightly differently, but it's still the same way. So in one of my other classes, I asked the question if anybody's taking proton pump inhibitors, and nobody said yes. And then I asked the names, and it came up there was Prilosec and Nexium. Says, oh yeah, I take Nexium. So you might not have known they were called proton pump inhibitors, but you might take one of those things. The purple pill as it's advertised. Yeah.
I was just reading an article about Talk pump inhibitors
Mhm.
been linked to increase heart attacks.
I have not heard that. And I've always been very impressed with this drug as a very low side effect profile. And they went to over the counter very quickly, Prilosec, OTC, that sort of thing, because it didn't really need a whole lot of physician oversight. So there might be some recent data that suggests that. I don't know any reason why that would make any sense. There might be some sort of proton pump in cardiac muscle tissue that's thrown off, but I don't know why. Or it might be something tied to pH. So, but I've not heard of that, and I've not known that there have been any real significant side effects to this particular drug. So a little bit more about the parietal cells in the book covers, but that's how they work. The other thing to consider about the stomach has to do with regulating stomach activity. Now, since I just opened this figure up on this tab, the title for the figure is gone, but it said gastric secretion or regulating gastric secretion. But really, this is regulating gastric activity, which is both secretion of the gland we just talked about, not just acid, but everything, as well as contraction of the musculature in the stomach. Okay, so just gastric activity. It comes in 3 stages. There's on the computer monitor that I'm looking at up front, it cuts off the names, but actually you can kind of see them. There's the cephalic phase, meaning what's associated with the head, the gastric phase, which is what's happening in the stomach itself, and the intestinal phase, which is how the intestines regulate stomach activity. So let me just enlarge this a little bit more. Not quite that much. So in this figure, what they have is a red arrow, which is suggesting the things that increase gastric activity, and then the greenish bar here that's talking about things that inhibit gastric activity. Really, cephalic and gastric phases are mainly increasing gastric activity, and then the intestinal phase decreases it. But there's a little bit in each of them that can affect the stomach in either way. The cephalic phase, meaning what's coming from the head, is really looking at how your nervous system, sensory systems, and autonomic system influence gastric activity. So if you see or think about food, both are processes that are handled mostly in the cerebral cortex, or you taste or smell food, things that are more basic functions of the brain and happening to have hypothalamus and medulla. Any of those aspects of encountering food will lead to activity along the vagus nerve, which is the parasympathetic division of the autonomic system, or part of it, which will stimulate secretion of gastric juices and contraction of gastric muscles. What this basically means is if you see, smell, taste, or even think about food, then your stomach is going to be more active. The idea is if you're about to eat, if you see the food you're going to eat, you smell the food as it's approaching your mouth, you taste the food when it's your tongue, or you just think about it if you watch somebody else doing it, or you're like, okay, I got to go get some food, and you start thinking about it, your stomach is going to become more active. You'll feel maybe some growling in your stomach or something like that, that we often associate with being hungry. It's not really being hungry, it's just the cephalic phase of gastric regulation. The advertising industry knows this happens. Okay, so you watch television and they have commercials of food that just looks beautiful, and you really want to eat it. You know, no McDonald's hamburger actually looks like what they have in the commercials, but it looks really appetizing the way that it is. Or if you walk across campus that way and cross the intersection, you'll go past Burger King. They pump the smells of what's in the restaurant outside so that you smell it. And all of those sorts of things are going to increase gastric activity and give you the impression that you're hungry. You're not really necessarily hungry, it's just that your body is preparing for food that it thinks you're going to eat. It goes back to before advertising and commercially available food was the norm, that your brain was wired so that when you were about to eat or you were starting to eat, that your stomach got ready for the food that was about to get there. Now there is a cephalic aspect to inhibiting gastric activity, which is worded a little oddly here, but there are various things that can cause you to lose your appetite. Now they say loss of appetite and depression. Depression can have added to it a loss of the impetus to eat or something like that. But there are a lot of other things that can also. My father's current wife, apparently when she was young, her dad was really kind of overbearing about her eating her vegetables. And so she just hates broccoli. But my dad and I, before he remarried, basically lived together. We were bachelors, a couple of guys. And he likes to cook. And so we had a kind of ritualistic regular dinner. And after I left the house, went off to college and stuff, when I came back to visit, sort of part of celebrating that is to revisit those dinner rituals and have sort of the same things that we ate a lot as we were two guys on our own. And one of the things we regularly had was broccoli with cheese sauce on top. And so when I came back from college and grad school and I came to visit, and by that time he'd remarried, his wife had to leave the house because she could not stand to be in the house smelling the broccoli cooking. And apparently my dad and I never really considered, okay, why don't we just not have broccoli? But she'd leave. I think she was fine saying, give us time to alone together, and she'd go out and get her own dinner or something like that. But she had a cognitive aspect that did the exact opposite of what you would expect when you're presented with food, and that cut down on her activity, her gastric activity. Now, the gastric phase is sort of the self-regulation of the stomach. The main aspect of what the gastric phase is about is if the stomach has food in it, it needs to digest it. The more food that's in the stomach, the more active the stomach needs to be to digest it. So there's two aspects that activate stomach through the gastric phase. One is distension, which means stretching of the stomach wall. So the more food you eat, the more the stomach wall stretches. And then there are also chemoreceptors that recognize the macromolecules that are part of food, as well as sense changes in pH. I'm fairly certain that they have this backwards here. It says food chemicals and rising pH activate chemoreceptors. It should probably be lowering pH, because if you have food in your stomach and you're digesting it, then your stomach's going to make more stomach acid, and the stomach pH is going to lower. And this is probably just a representation that people often get increase in acid, decrease in pH backwards. So I think this should be a lower pH. And all of that stuff's going to lead to activation of tissues in the stomach to be more active. As stomach acid gets too high, if the pH starts to get really high, and maybe that's why they're put rising here, because this is lowering pH. So they're saying, oh, the opposite have to be opposite. But I think it's as pH lowers from 5 to 4 to 3 to 2, that's going to increase gastric activity. But then when it gets below 2, the stomach's saying, whoops, too much acid, and it cuts back on how much acid it produces. Okay. And then they put here emotional distress, which really is cephalic phase cognitive problems, and that might very well describe my stepmother's reaction to broccoli. But what they're pointing out here is that sometimes that reaction, a very emotional reaction to food, might be tied into a fight or flight type of response. And the sympathetic system is going to decrease gastric activity because there's no point in trying to digest food if you're running away from something that's looking to digest you also. But the sympathetic system overrides parasympathetic controls of the stomach. So I think they're putting this here because this sympathetic override of parasympathetic is happening in the submucosal and myenteric plexus. But really, it's ultimately driven by emotional states, which are coming from the head and really should be stopped. So mainly the gastric phase inhibition of gastric activity has to do with extreme drops in pH. And then there's the intestinal phase. Let me just dispatch with this in a couple of minutes so that I can wrap this idea up. Namely, the intestinal phase is about negative feedback to the stomach because it wants to limit the activity of the stomach since the intestines can't stretch out to accept a whole lot of food at once. So distension of the duodenum or the presence of macromolecules, the things that activated stomach by the gastric phase, will actually inhibit the stomach from the intestines. When they get to the intestines, it sort of tells the stomach to slow down a little bit. It can do that either through local reflexes or autonomic controls, meaning nervous system stuff, or there are hormones that play a role in that. We're going to talk about a couple of these hormones in a different sense, but here they're kind of listed. The one sort of stimulatory part of the intestinal phase is just as food starts to enter into the small intestine will say, okay, we're ready to break things down, or ready to accept food, and it releases its own version of gastrin, which will increase stomach activity. So that wraps up that idea. We'll come back and I'll say one or two last things about this whole thing on Tuesday. And then hopefully I'll be able to finish up the digestive stuff on Tuesday, and we'll move on to the urinary stuff next Thursday. So have a nice week. Weekend, whatever.